Hi, I'm Maria Tan, nursing student at Western Sydney University, 2016-4427. I will be discussing about hypoxemia in patient with asthma with SpO2 of 92 and one high priority nursing intervention, which is the administration of oxygen. Jackson Smith, an 18-year-old male, was admitted to the hospital, to the emergency department, with severe breathlessness, with a history of asthma since he was 2 years old. Upon admission to the emergency department, Jackson had several clinical manifestations that was identified. Among those clinical manifestations, I am addressing Jackson's SpO2 of 92%. The image below shows a normal bronchial tube and a constricted bronchial tube in patient with asthma. Asthma usually is characterized by chronic airway inflammation that is associated with coughing, wheezing, shortness of breath, and chest tightness, along with limitations in variable of expiratory airflow. One of Jackson's clinical manifestation is having SpO2 of 92. This hypoxemia is triggered. Asthma is triggered by some response of our body in medication and some allergens from food, animal danders, some environmental irritants from pollens, grasses, and weeds, and others are from exercising and cold air, as well as cigarette smoke, stress, and respiratory infections. All these factors triggers the mast cells to produce inflammatory mediators that will cause inflammation of the bronchus and harbor goblet cells, hyperplasia, which rapidly give rise to the mucus secretion along with remodeling of airway wall happens through the formation of fibrosis. Any decrease in surface area available for diffusion impairs the oxygenation and is called airflow resistance. The narrow bronchioles decreasing airflow rate and airflow resistance describes factors which limit the airflow of air to the alveoli, will make the exhalation impaired, causing air to be trapped inside the alveoli, making the alveoli hyperinflated. That makes breathing more faster due to the increased demand on air. Moreover, increasing alveolar gas pressure and intrapleural gas pressure that will lead to the decreased alveolar perfusion. Therefore, will elicit uneven ventilation perfusion that lowers pulmonary blood flow as gas exchange in the alveolar is impaired, which will then contribute to which will then be a manifestation of hypoxemia or low oxygen saturation in the blood. As the lung receptors respond to the hyperinflation of the alveoli, the deficient in carbon dioxide and hyperventilation occurs, along with the arterial blood gas abnormality. If left untreated, the ventilation of the alveoli becomes low. Air continuously gets trapped, and the demand for oxygen gets higher, presenting hypoventilation, retained carbon dioxide, and respiratory acidosis that will trigger respiratory failure. One high nursing priority intervention is administration of oxygen. Oxygen administration increases the alveolar oxygen concentration and facilitates its diffusion across the alveolar capillary membrane, reducing hypoxia and anxiety. Oxygen administration also reduces hypoxemia and retained hypoxic drive. The hypoxic drive is a form of respiratory drive which the body uses oxygen chemoreceptors instead of carbon dioxide receptors to regulate respiratory cycle. As an early improvement in respiratory work and subsequent enhancement in making the patient comfortable are paramount to avoid complications such as atelectasis and progressive respiratory exhaustion that will lead to respiratory failure. Of all emergencies, respiratory problems must be treated first. Without a patent airway and breathing, your patient will deteriorate immediately and nothing else matters. Therefore, as an emergency nurse, you must be able to recognize and rapidly respond to a respiratory emergency.